The following podcast is part of a certified educational activity titled Off the Shelf and On the Mark in NHL, Strategic Approaches with Bispecific Antibodies and ADCs. Access the entire activity and complete the post-test at peerview.com/DCA860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Sameh Kabala from Moffitt Cancer Center here in Florida. Welcome to Off the Shelf and On the Mark in non-Hodgkin's lymphoma, strategic approaches with bispecific antibodies and antibody-drug conjugates. During this program, we're going to be reviewing how the current guidelines are reflecting evidence that supports the integration of newer off-the-shelf options with a specific focus on antibody-drug conjugates and bispecific antibodies in different lymphoma settings. I'm going to be reviewing some of the updates, particularly newer combination strategies with these two modalities, and cover data on emerging bispecifics that may soon make a difference in your practice. We're also providing a downloadable version of the dosing information that we're including in this program as a practice aid, and you would have that. You could access that as a resource. So let's begin. So antibody-drug conjugates in non-Hodgkin's lymphoma. So basically, these are antibodies that are attached to a target. Attached to a drug, and typically the antibody would attach to a target on the cell, gets engulfed by the cell, and that releases the drug inside the cell and causes cell killing. There's different agents now approved. Pola-R-CHP targets CD79B. And that is currently approved in diffuse large B-cell lymphoma as early as first line. We're going to review some of this data. Brentuximab is also now approved. Initially, it was approved in Hodgkin's and peripheral T-cell lymphomas, but recently has also been included in the NCCN guidelines for diffuse large B-cell lymphoma in combination with rituximab and lenalidomide. Loncastuximab tesirine targets CD19. And currently, it is approved in the third-line plus setting in diffuse large B-cell lymphoma. There's also other investigational agents and emerging data. For example, we have zilovertamab, which is this targets ROR1. So the current status of bispecifics in non-Hodgkin's lymphoma, we have a few agents now approved. And bispecific antibodies, so these are T-cell engagers with an antibody that basically has two targets. So one attaches to your T-cells through CD3, and then the other portion of the antibody targets the cancer cells. And we currently have CD20 as targets, but there's more and more different other targets, and that basically causes leads the T cell to go in and kill the tumor cell. So mosunetuzumab is currently approved in follicular lymphoma, both in the U.S. and in Europe, in follicular lymphoma third line space. Epcoritamab has approval for both diffuse large B-cell lymphoma and follicular lymphoma in the third line space. Glofitamab is currently approved in diffuse large B-cell lymphoma in the third line space. Odronextamab is currently approved only in Europe and is being reviewed by the FDA in the US. Okay, so why do we need new options in lymphoma? So there are still unmet needs. So in diffuse large B-cell lymphoma, patients who fail CAR T-cell therapy have a poor prognosis, particularly depending on how soon after CAR T failure, after CAR T cell failure. So obviously, the worst prognosis are patients who relapse early, around day 30. These are patients who have the worst prognosis post CAR T failure. But still, this is an area of unmet need. And the other area of unmet need as well is in follicular lymphoma. In patients with POD24, patients who progress within 24 months of chemoimmunotherapy. These patients also have historically have had worse survival. CAR T-cell therapy has made a significant improvement there, but there's definitely still space for improvement. The ZUMA-22 trial, phase 3, completed accrual, and we're still waiting on results. which looked at CAR T-cell therapy in these patients with POD24 in the second line. So, what are we going to focus on and try to learn today? I'm going to review the antibody drug conjugates and bispecific antibody data in the management of non-Hodgkin's lymphoma, including earlier lines as well as recent data in this space. Um, I'll review these are off-the-shelf treatments, and I'm going to review the dosing and some of the safety considerations when using these agents, including the pre-medications and the step-up dosing requirements. We'll also look at some newer strategies, looking at combining some of these antibody drug conjugates and bispecifics, or some of the newer emerging bispecific antibody data that look promising in follicular lymphoma and diffuse large B-cell lymphoma. Okay, so if we look at currently the NCCN guidelines in terms of management of patients with diffuse large B-cell lymphoma, so the polatuzumab has made it to the first line based on the Pola-R study. This was a randomized phase 3 study that looked at Pola-R-CHP versus R-CHOP, and there was a PFS advantage. We now have a 5-year update, which continues to show an advantage for the Pola-R-CHP over R-CHOP. There's still no overall survival benefit, but we're looking at more and more longer follow-up data. Of note, the difference in the PFS was more stark in the subgroup of patients with non-germinal cell histology. There's still unmet needs, so patients who are above age 80 or frail, the standard is still a mini R-CHOP. There's other regimens to introduce gemcitabine or etoposide instead of the anthracycline, but this is a big area of unmet need. Patients with poor left ventricular function, we try to limit the use of an anthracycline in this setting. Dose-adjusted R-EPOCH is an infusional treatment, so that could be, potentially used in this setting. But there's also other agents, again, utilizing gemcitabine or etoposide instead of the anthracycline. When we move on to the relapse setting, so patients with relapsed diffuse large B-cell lymphoma who are relapsing less than 12 months out or with primary refractory disease, again, these patients typically have very poor outcomes with the prior standard, which used to be salvage chemotherapy and autologous transplant. And now these patients are recommended to undergo CAR T-cell therapy. There's 2 agents approved here, Axicell and Lysocell, and that was based on the ZUMA-7 study and the Transform study. CAR T-cell therapy has obviously some of the limitations because it needs a lot of logistical considerations. Sometimes we need to do bridging therapy while we're waiting for the CAR T cells to be made and ready. And most commonly in the U.S., we typically would consider polatuzumab or rituximab. I know they have the bendamustine on here in the NCCN, but we typically try to avoid the bendamustine in this setting because it's lymphodepleting. You could use it after the collection of the T cells, but try to avoid it prior to collection because it could cause damage to the T cells. Now, the problem is patients who are not candidates for CAR T cell therapy or they don't have access to it. Those are the patients that there was some unmet need in the space. And now on the NCCN guidelines, they have incorporated the bispecific antibody combinations based on some of the studies that I'm going to be reviewing with you. So there's ocrelizumab GEMOX, there's glofitamab GEMOX, there's mosunetuzumab. There's also the Pola-BR, and these are now on the NCCN as early as second line in patients who are not candidates for CAR T cell therapy. What about patients who relapse later, so more than 12 months out? The standard for these patients is still salvage chemotherapy followed by an auto transplant. And again, these were the patients who were excluded by the CAR T trials that looked at the CAR T in second line. So But sometimes patients are not, not eligible or cannot withstand an autologous transplant. And for these patients, you actually can consider Lysocell. So Lysocell has a label in patients who are not transplant candidates in the second line, who are late relapsers after 12 months. Other options there also include bispecific antibody combination treatments, such as the ones that I just mentioned previously. Again, those are NCCN recommendations. Okay, so um, what about third line space? So in diffuse large B-cell lymphoma, these are FDA approved in diffuse large B-cell lymphoma, epcoritamab and glofitamab in the third line setting, as I mentioned. But again, as I mentioned, I'm going to be reviewing some of the combination studies that try to build on single agent use of these agents. In follicular lymphoma, we have 2 bispecific antibodies approved in the third line setting, as I mentioned, and those include epcoritamab and mosunetuzumab. CAR T-cell therapy is also approved in this setting. Okay, so this is a summary of the data that led to the approvals of the single agent bispecific antibodies. So epcoritamab has a CR rate in large cell lymphoma of about 39%. Glofitamab, very similar, around 40%. If we look at mosunetuzumab, it's 60% in follicular lymphoma CR rates, overall response 80%. With epcoritamab, again, very similar, 63% CRs, overall response rates is 83%. So as you're going to see, the different bispecific antibodies, they have similar responses between them. They do differ, however, in the duration of therapy, the mode of administration, fixed duration versus endless therapy, and I'm going to be discussing that next. Okay, so in terms of antibody-drug conjugates, so if we look at polatuzumab, that in the first-line setting combined with R-CHP, so Pola-R-CHP, that is administered every 3 weeks as an intravenous infusion. The polatuzumab portion is 1.8 milligrams per kg. Pre-medications are antihistamines and antipyretics. And the R-CHP dosing is just standard dosing, similar to the R-CHOP dosing, obviously without the vincristine to avoid neuropathy. The dosing for loncastuximab. So loncastuximab is given as IV. It's given every 3 weeks. The first 2 cycles are a larger dose, so 0.15 milligrams per kg. And then starting cycle 3 onwards, the dose drops in half, so it's 0.075 milligrams per kg. One thing about Lonca, though, is the pre-medications include dexamethasone 4 milligrams to be done a day before, the day of the treatment, and a day after the treatment. And typically that has been found in the phase 1 study to reduce the adverse events for loncastuximab. So that's one thing to consider. Sometimes patients would show up in the infusion center and they forgot to take their dexamethasone the day before. So the recommendation in this setting is to just go ahead and give the dexamethasone, wait 2 hours, and then proceed with the treatment. Okay, so now moving on to the different dosing schemas for these bispecific antibodies. So mosunetuzumab, again, approved right now in follicular lymphoma. There's obviously data using it in diffuse large B-cell lymphoma, particularly in combination with polatuzumab, as I previously mentioned. So mosun is given initially during the ramp-up phase, once a week on day 1, 8, and 15. The target dose is given on day 15, which is the higher dose of 60 milligrams. And that's typically the dose that may be associated with some of the adverse events, particularly CRS. So this is when you want to educate your patients to look out for. Typically, it's usually low-grade CRS, meaning they usually have fatigue, fevers, sometimes tachycardia. But obviously, in the rare event that they have more severe CRS, like hypoxia or low blood pressure, these patients need to be hospitalized and managed with the CRS as such, with steroids, tocilizumab if needed. But that's again, it's low incidence of severe CRS, and it's also lower intensity compared to CAR T cell therapy, and that's why these bispecifics can be done as outpatient. Subsequent doses are done intravenously again every 3 weeks. And after 8 cycles, we would do, an assessment with a PET scan. If they're in CR, they could stop at that point. So mosunetuzumab was designed as a fixed duration therapy. If they have stable disease or a partial remission, you can continue treatments up to 17 cycles. Um, there's emerging data with mosunetuzumab being administered subcutaneous, but as of right now, the approval is for the intravenous use. The initial, cycles, the duration is longer, so it's 4 hours during the ramp up, but then subsequent cycles, it's quicker at a 2 hour infusions. And again, all mosunetuzumab is outpatient and it's a fixed duration therapy. The next agent is glofitamab. Again, glofitamab is intravenous. Day one, however, obinutuzumab pre-treatment is given. And the purpose of that is to clear some of the circulating tumor cells, and that can lead to a lower cytokine release and toxicities. So that's the purpose of the obinutuzumab. And then the ramp up is done on day 8, 15, and then day 1 from cycle 2. The highest incidence of CRS here typically is around day 8 with the first dose of the glofitamab, and that's why it's recommended to do a 24-hour hospitalization after day 8. Some centers are, trying to do this as outpatient as well with some mitigation strategies. But again, most of the CRS is going to be typically seen on day 8. Again, if a patient develops CRS or toxicities on day 8 and they've been observed, we typically recommend that day 15 would also include an observation for 24 hours. Glofitamab is done as a fixed duration therapy, meaning that from between cycles 2 and 12, it's given intravenously every 3 weeks for a total of 12 cycles. So it's a fixed duration therapy. Epcoritamab is subcutaneous, and it's given more frequently, however. So during the first 3 cycles, it's done weekly, and then cycles 4 to 9, it's bi-weekly, and then subsequently, it's monthly. There is some differences between the follicular lymphoma and diffuse large B-cell lymphoma frequency. So, for example, the follicular lymphoma dosing optimization includes a 3-step-up dosing. So on day 15, they still get a lower dose of 3 milligrams instead of the full dose of 48 milligrams. And what that led to was pretty much, significantly reducing in half the CRS incidence as well as severity. The diffuse large B-cell lymphoma is still a double step up, so they get the full dose on 48 milligrams. But again, some people use this as off-label, the follicular lymphoma dosing with the diffuse large B-cell, because with the follicular lymphoma, it's, triple step-up dosing, it's all outpatient. Whereas with the double step-up dosing on day 15, it's recommended to do a 24-hour observation. Epcoritamab, however, in the initial studies were not fixed duration. They were done till disease progression or unacceptable toxicities. Although there's newer strategies and data now, that are looking into a more, fixed duration strategies. But as of right now, this is the approval for it, at least in diffuse large B-cell lymphoma. All right, so I'm going to go now next into some of the updates in clinical data with bispecifics and antibody-drug conjugate combinations. So the first study is the STAR-GLOW study, and this study looked at glofitamab with GEMOX in diffuse large B-cell lymphoma. It's a phase 3 trial, and it was compared to R-GEMOX. And the primary endpoint here was overall survival, and the study did meet its endpoint, showing better survival with the addition of glofitamab to GEMOX when compared to R-GEMOX. CR rates also significantly improved, 58.5% CR rates compared to 25.3% in the R-GEMOX. The study included many patients in the second line, and that's why it's including now on the NCCN guidelines. It's not FDA approved, this combination in the US. However, because there was fewer US patients on the study. However, it is, as I listed initially, one of the options on the NCCN guidelines as early as second line in patients who are not eligible for CAR T cell therapy. This again is a fixed duration therapy, so the GEMOX component is given for a total of 8 cycles, and the glofitamab goes on to 12 cycles. The next study that was recently presented at the EHA this year, 2025, is the Pola-R-Go study, and that looked at polatuzumab, rituximab, GEMOX in patients with relapsed refractory diffuse large B-cell lymphoma compared to R-GEMOX in a randomized phase 3 study. We're seeing an overall survival benefit. Responses were also significantly higher in the polatuzumab-containing arm. One word of caution, however, the incidence of infections was and cytopenias was higher in the polatuzumab-containing arm, as well as a higher incidence of neuropathy. Again, you're including here polatuzumab and oxaliplatin. Both can cause neuropathy. There were a few patients with grade 3 neuropathy. So this is, if you're going to be using this regimen, you just want to, again, monitor for neuropathy and consider, adjusting your strategy if the patient is developing any toxicities in terms of neuropathy. These are the response rates. If we look at the best response rates here on the right, again, CR rates of 47.3% with the addition of polatuzumab compared to 23% with the R-GEMOX. So, just going through, this data now, I just wanted to include some of the scenarios where you might consider, these newer off-the-shelf options and how they could make a difference. So, for example, if you have a newly diagnosed patient with diffuse large B-cell lymphoma, this patient, for example, 68 years old, coming in with a newly diagnosed diffuse large B-cell lymphoma, stage 3, IPI 3, no significant cardiac comorbidities. This would be an ideal patient for polatuzumab R-CHP, and this is FDA approved at this point. In the relapsed setting, if we look, for example, at a patient who's 72 years old with a relapsed refractory diffuse large B-cell lymphoma, who is ineligible for CAR T-cell therapy and or just does not want to do CAR T-cell therapy. For example, I recently had a patient coming in to referred to us from the community. He lives 3 hours away, and he's just not going to be able to travel for CAR T-cell therapy. So that would be another ideal patient to consider second line glofitamab GEMOX, and again, that is included on the NCCN guidelines. In terms of follicular lymphoma, so if you have a patient with, relapsed follicular lymphoma, so for example, a patient who's 65 coming in with relapsed follicular lymphoma after receiving 2 prior lines of therapy, coming in with progressive follicular lymphoma that's symptomatic and needs therapy, bispecifics are definitely an option there. We have 2 approvals. We have mosunetuzumab and accredited. What about, most recent data? So in terms of combinations, so recently at the Lugano meeting, we've had the very early data with the LOTUS-7 study, which combined loncastuximab with glofitamab. They used 2 dosing schemas, 120 micrograms or 150, and they combined it with glofitamab. Again, both of them are given every 3 weeks, so the schedule lines up well. And they basically presented, again, very few patients, very preliminary, but it looks promising. There were 15 patients presented. Half of them were in the second line setting. 20% of these patients had previously received CAR T-cell therapy. And at least in this cohort, the CR rates were 86.7%. Obviously, this will need to look at further data and expansion of the of the doses to see. I mean, basically, we have 15 patients in each arm now, so the total patients is 30 patients, but we'll obviously need to see more patients and expansion of this cohort beyond those 30 patients to investigate those responses. What else is out there, and what are the new agents out there? So one of the promising agents is AZD0486. That's an emerging bispecific antibody. Now, the difference with the different thing about this antibody is it targets CD19. The others that I just went through have all been CD20. And this bispecific antibody was designed so that first of all, it's fully humanized, but the CD3 binding site actually has low affinity to CD3, and the design was thought that if we design it in such a way that would lead to reduce the cytokine release side effects. It has a high affinity, however, to the CD19 binding sites, to the malignant B cells. And right now we have data with phase 1 and relapse refractory diffuse large B-cell lymphoma and follicular lymphoma, and I'm going to go through them next. So the study schema. So this is again a phase 1 study. It's been through multiple iterations. Initially, a fixed dosing escalation, and then a single step-up dosing. And the most recent data has been with the double step-up dosing, where the patients get a priming dose on day 1 and 8, and then the target dose on day 15. And then thereafter, they're getting it every 2 weeks. Patients who achieve a CR after 6 cycles may switch to a less frequent administration every 4 weeks instead of every 2 weeks. And again, this is a phase 1 study, and we're still investigating the target dose here. Most recently, the follicular lymphoma cohort of patients has shown very, very high activity at this time. So if we look at the whole cohort of 41 patients, the CR rate is 85%, and that's in 41 patients again. And these patients can include some of those high risk patients. So, for example, there were 14 patients with POD24. There were 6 patients who are CD20 negative, 6 patients who had refractory disease. There were 4 patients who previously failed a CD20 bispecific antibody, 6 patients who previously failed CAR T cell therapy, and we're still at achieving significant complete remissions in this setting. So again, this bispecific looks very promising in full relapse refractory follicular lymphoma, particularly patients with a high risk follicular lymphoma, and we're going to be watching further data as they come out. In terms of diffuse large B-cell lymphoma, it also has excellent activity, and including patients who are CAR T naive or CAR T exposed. So in this most recent update, we've had 31 patients who are CAR T naive and 27 patients who are CAR T exposed. And you could see here the different dosing levels, and unlike follicular lymphoma, we're now investigating higher doses, 50 milligrams and 25 milligrams in diffuse large B-cell lymphoma, with CR rates between 50 to 67%. So I think this again is a single agent activity in very heavily treated patients, high risk patients, including those who are previously CAR T exposed. So we'll keep an eye on this. This is again also given as a fixed duration therapy, so it's given for up to 2 years. In terms of toxicities, so cytokine release syndrome has been relatively low, with 49% of patients experiencing CRS, but they're all typically grade 2 or lower. The majority of these are actually grade 1. There is cases of neurotoxicity that are seen, again, mostly low grade 1, 2, few patients with grade 3, but these are typically transient and reversible. It might have to do with the CD19 targeting. But again, for most patients, this is transient and reversible. Other side effects similar to any of the bispecific antibodies is obviously going to include infections or cytopenias. So these are, these are going to be common side effects that are going to be seen with any use of any of the bispecifics. In conclusion, this is, a very exciting time. We're having more and more options for patients who are, where there's an unmet need, particularly patients with diffuse large B-cell lymphoma who have failed CAR T-cell therapy, or using some of these newer agents in the second line in patients who have no access to CAR T-cell therapy. We're seeing very exciting data with now trying to combine some of these agents, including combining antibody drug conjugates with bispecific antibodies, and expanding those again to the as early as second line, and they're now included in the second line in NCCN. And these patients, obviously you need to pay attention to some of the mitigation strategies, particularly during the step up dosing, so that you monitor these patients for CRS and neurotoxicity. But again, usually once you get to cycle 2 or 3 or beyond, the incidence of these side effects diminishes significantly. But at that point, you would want to focus more on monitoring for infectious complications, which can happen at later stages. I'd like to thank you very much for your attention, and looking forward to seeing you again in the future. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent educational grants from AstraZeneca and Genentech, a member of the Roche Group. To access all materials for this activity, visit peerview.com/DCA860.